Welcome back, everyone. We're here with another episode of RetFix and Chill. We're doing our series on macular holes, whether they're complex, chronic, or recalcitrant. We all have different ways of approaching them. Today, we have Dr. Parjan Arjman from the Mississauga Retina Institute in Toronto, Ontario, and she'll be talking to us about her approaches using ILM flaps and different ILM techniques. Nice to have you here.
Good afternoon. Thank you so much for having me on your amazing podcast, Dr. Zahid. So I will show you a few videos today and I'll keep it interactive so we can chat. And I'm curious to also see everyone's comments about what they would do differently. So I'm going to start with a case actually that I haven't shown before. Are you able to see this?
Yes.
Okay, perfect. So this is actually a case of a patient that I operated on last week who is a high myope status was LASIK with a medium macular hole. So just, the basics, I induced the PVD. As you can see, there is no PVD, but the hyaloid nicely came up. And here I'm using a flat contact lens. For this part of the surgery, I use brilliant blue, of course, and then nice stain, as you can see. I used my regular ILM forceps. And I found it really challenging actually to reach. In these high myopes, sometimes it can be really hard to reach the fovea because it's so far. And I was wondering to myself, look at the ports in a weird place, or is it just the eyeball is really long? So I started blaming the instruments first, as normal people usually do. And then I asked the nurses for a different set of forceps to try to mitigate. I was having some issues just grasping the ILM. And so I used a myopic chair. And I still was having trouble like having a smooth peel here. I had to do a nice flat for this medium hole in this gentleman. And as you can see, I was struggling a little bit, it was a bit slow. And so I'm curious, what would you do, Sarah, in this situation if you're just struggling a little bit with reaching the ILM? You use two different forceps and then and back.
That's a great question. And it's, really, great of you to show us, not just your successes, but also things that you struggle with, because we all go through this, on a daily basis. I think, one of the things that we don't have in our armamentarium of data when we do these cases are axial lengths, because if we did, then I would consider a 23 gauge instrumentation, obviously because those instruments are slightly longer. In this situation, like one thing I really like to use, I'm less of a pinch and peeler. I like to use the flex loop. And I think the flex loop gives you that extra bit of length to at least get the flap to a point where you feel comfortable grabbing it. So that's one thing I would
Right.
consider trying here. But I'm also not as probably as adept as some of these ILM flap techniques as you are. So I'm curious to see what you did here.
No, you're kind. So I don't, we don't have the, the sloop that you mentioned. I've actually never used that in my career in Canada. It's just, I guess, not as common in our area. But I did use a Tano. I asked the nurses to open a Tano Diamondus scraper. And as you can see, it made my life so much easier. I literally just, it's kind of like doing the capsulorhexis, using, the needle alone without forceps. I feel like doing the rhexis here on the ILM without using forceps entirely, without damaging the retina in any way. It's a very gentle peel, but it allowed me to even have a nice flap at the end, which I'm going to show you in a sec.
Love that. That looks great.
No, it looks like there's like a little rod there on the tip of a macular hole. And then I completed the rest. As you mentioned, like it makes it a lot easier then to grasp with your long forceps. And so it just made the case so much easier. And, I think it was just nice to show this because, as you mentioned, like we do all kind of run into these routine cases that sometimes become a little bit difficult unexpectedly. And then I actually do like to use the slightly wider field IO attachment. I don't know if you use that in your OR. And the Zeiss attachment, which is still high MAC, but not the flat contact lens. To just peel off the remainder of the edges. And then I'm doing the fluid air exchange. You can see the flap there still staying on top of the macula at the end with the fluid air exchange. This gentleman was actually 2060 close to 81, his full close. Anyway, so that's just the first case I was going to start with. And
Do you use it was this 25 gauge?
no, I actually only do 23
Also,
gauge right now in my OR.
gotcha.
Yeah,
No, 23 gauge is
just that.
great because though you have that extra length on the forceps. So I think that's, in many ways a big benefit of using 23 gauge. Do you flap it over after you do the air fluid exchange? And in this case, what sort of tamponade did you use? SF6 or did you go with air?
So I tend to just use the forceps gently to place the flat almanacular hole, carrying enough to touch the RP or the retina. And then in some cases where I'm paranoid, which I will show you in a sec, for like extremely large holes or chronic holes with round edges, I do multiple flaps, like 3 or 4 clots on top of each other, and then I inject this with cohesive
Mhm.
material. That's after doing this thorough fixation. Sorry, the thorough depressed exam. So once I'm sure that there's nothing in the periphery, everything is done. At that point, I go back and then put all the flaps on top of each other using the forceps. If I have a tunnel already open, sometimes with gentle with tunnel also helps. I put the flaps on top of each other into the hole, but not like inside the hole. I just put them on top. And then after injecting this viscoelastic material, I go to fluid air
Do you have any
exchange. And then,
sorry about that. Do you
yeah.
have any tips on when you're doing the air fluid exchange? Sometimes it can move. Some people say doing the air fluid exchange over the nerve to direct the flow of fluid in a certain direction is helpful. Is that something that you have any recommendations there?
Yeah. I mean, I actually tend to put a little bit superinasally, so that it tends to suck the flap a little bit towards the nerve. It depends on which direction your flap hinges at, because their infusion is temporal, right? And so if you're sucking from the opposite direction, as you're doing a gentle FAX, that flap comes to stay. I'll actually show a video of that as well. One that didn't happen and why I did to mitigate that. And for tamponade, I use SF6. I always use SF6
Gotcha. Yeah, same here. I almost
for,
always use SF6. I don't have the courage that some of our colleagues have, even for small holes, to use air unless it's straight
um,
up VMT.
I know, same. Even for VNG, sometimes, to be honest with you, sometimes even for VNG, I use
Yeah.
SF6 if I'm paranoid that it's too traditional. Anyways, all right, I'm going to show a couple complications or basically issues that you might come across or our audience might come across during, ILM flaps for macular hole surgery. And so one, for example, is if you're trying to do a flap and if you pull a little bit too hard, you can easily amputate the flap. I'm sure this has happened to all of us, but I find that if you put some tangential force around the flap edge and regrasp multiple times, an amputation can be avoided. In this situation, I didn't. Just pulled a little bit too hard at the end, and the entire thing came off.
Happens to me like in every
Um,
case, you know, so
was
it's always being amputated. I'm like, oh, I have this such a nice flap. I'm like, oh my God, look at that rexus. And then it's like all of a sudden it's like popped off. You know, it's a great feel.
I know. She's like, "Is everything okay?" You're like, "Yeah."
Yeah, it's the problem with being a perfectionist, you know.
Absolutely. And then the second thing I guess that can sometimes also happen is if you use your cutter to just clean up around the flap a little bit or try to trim the flap, you might inadvertently stuff the flap if you're not careful enough, if the vacuum is too high, for example. This is another very large hole. At the end, I was just trying to trim that flap, and then as you can see, I unfortunately ate it with the cutter. Um,
You don't you
and
do you
sometimes
have to trim it at all? You know, do you feel is it okay to just leave it a little bit longer because of the risk of the amputation with the cutter there?
I think that's an excellent point. I think at the beginning, when I first started doing a lot of these flaps, I was trimming them just because that's what I'd seen in fellowship. But now, as you said, exactly, I don't think there's a need to trim it. Actually, the longer the better. Yeah, I don't think there's any harm to having long flaps. In fact, we are doing a study with another center, retrospective study at looking at OCT features of these patients who've had flaps to see, if it has any bearing on their vision or if it impedes healing or hasteness. I think it's an interesting thing to look at.
Great. No, looking forward to see the results of that study. Cool case.
Right, thank you. And then this is another situation where I was trying to, as you can see, this one's like a very long flap, so I was trying to kind of trim it a little bit, make it look nicer, maybe feel better about it. But unfortunately, I trimmed it a bit too short. It's like having too short of bangs when you're cutting your own hair. I mean, this still closed, but that flap was a lot smaller than I would have wanted it. Just an inadvertent effect of using the cutter to trim it. And then also, as you mentioned, a lot of us face this challenge at the end. You do a nice flap, we put everything back together. This is a very large hole in a patient. We had staff for both over a year. As you can see, it's a large hole. I did a nice flap, put the flap using my actually soft tip backslash cannula to gently place it on top of the hole right there. And it's sitting nicely. This is after this girl the best exam. I went to the nerve. I'm doing the very gentle fluid air exchange. And the flap moved. I don't know if you could appreciate that. Maybe the contrast is not that high, but right
Mhm.
there, the flap is no longer in the hole.
It shifted in barely.
So Yeah, exactly. Some of the solutions that I would recommend is, try to cut on zero section if you can manually adjust those settings at the time of trying to trying to trim the flap, or just don't trim the flap at all. And also very slow hand movements with the forceps, of course, when you're doing the ILM flaps. It's very easy. It's probably second nature to most surgeons like yourself when you're doing a peel, but just to take that extra second to not pull so hard at the end will ensure that the flap stays. And then also doing multiple flaps as a backup plan is great. Like every time you do a rexus and then you larger rexus, larger and larger, having multiple flaps I find is a security measure so that if one or two of them is gone, at least you have a backup option. And, I did watch a lot of surgical videos, especially about a year and a half ago when I was, getting more comfortable on my own doing these cases. I think coming up with a consistent surgical technique that works for you every single time might be also like the ideal for some of our audience. So in my case, for example, I do in a triple kind of three-step fashion. I do a little counterclockwise half circle, and then a clockwise circle, and then I enlarge that further. I always do it the same way, unless if the anatomy is different. And so I find in this case, I definitely always get multiple flaps, especially for like, extra large holes.
Do you
Um,
mean
and
like multiple florets of the flap? Is that what you mean? You start at a different location to start a separate flap?
I started a different location, yeah, and I'll show you this right now. Actually, in this case, this is a gentleman who had a very dense cataract too, but it was referred to for a cataract surgeon. It's a very large hole, as
Oh,
you
it's
can see
chronic.
on the 918 microns. I know, and I told him it's may not close, but here I'm doing that. I did that first half circle, left a flap at the end, and then the second half circle, leaving a flap again there. So I guess I call these multiple flaps, and then another counterclockwise rotation. And then you can call this like a rotational flap. It's not at the edge of the hole, but then I went in and stuffed all three um, using container scraper and viscoelastic into the hole.
So all three of them are over the hole. Okay.
That's right.
And
Exactly.
are they
I mean, and if you can one, then no big deal because you already have another few. So this is kind of the outcome at the
are
end.
they
And then,
over the hole or are they in the hole? Based on what are
I
you
don't
aiming
know.
for?
I'm aiming to cover it on top of the hole. I'm not aiming to place it inside because I think that really traumatizes the RPE. It's kind of like when you do amniotic membrane cases, sometimes, manipulating around the edges of the hole a bit too much can traumatize the RPE. So my aim is to be on top of the hole, but then to stay there. And so I inject this of this go cohesive at the end, and then you can see at the end of that FAS that there's like a nice blue on top of the hole, and those are my flaps. And the OCT there at the bottom is this patient at post-op week 2.
That was great.
Um,
Amazing.
yeah, you see this line over
Yes.
here? So that's what I'm talking about for the flash, like still persistently showing up on OCT post-operatively. And for example, this is another patient. It's actually a patient from the Caribbean fluent just from macular hole repair. Post-op week 1, it was like I did a flap on her, similar. It's 877 micron hole, and it looked like her hole wasn't closing. I was a little bit nervous. I just encouraged her to continue face down, and 2088 post-op month 1, she emailed me saying that her vision continues to improve 18 months later. So it's
That's
nice.
really great. I like the idea of not putting anything inside the hole. I mean, even with amniotic membrane, it's a technique I'm sort of starting to get better at. I don't like the idea of stuffing stuff inside the hole simply because you just don't know what sort of visual recovery you're preventing. In these cases, in the OCTs that you showed, you see some reconstitution of the outer retinal structures. Now, like we don't know about the neuroplasticity of these tissues once the hole is reapproximated, but you know, I feel like if there's no foreign tissue there, you have a better shot at reconstituting and regaining some vision.
I agree. And also, I'm sure you've seen some atrophy post-op with some of these large holes, and there's something that very attached to the RP. I always wonder, is that because of the hole or is that because of the surgery? It kind of almost looks like geographic atrophy. So I try to avoid that as much as possible by not touching on the macula.
Yeah, but
Uh,
in the same vein, whenever you look at OCTs, it's part of the reason I stopped pinch and peeling. I was noticing that, at the landing sites, even with some of the newer forceps with shark skin from Alcon, for example, and some of the other manufacturers make some great forceps, but maybe I'm just not gentle enough to not create trauma. So I like starting the flap with a flex loop, which, you know, um, it's similar to the Tano scraper, but it's a different length. So if you bring out the loop further, it's less traction on the retina. Whereas if you withdraw it, it becomes more of an omega, a smaller omega shape, and that generates greater traction. So depending on the elasticity of tissue that you use, so that's why I like starting with the flex loop. But
Nice. I'm gonna try that because I know exactly what you're talking about. I've definitely seen my, deep grafts for sure. For some cases at that
yeah,
initial start, like patients may not notice it, but anyone who lives with those people never really start at the
yeah,
tail.
it's a lot of the times, when we're looking at our own post-op results, it's usually ourselves, that we're judging, we judge ourselves pretty hard. It's like, oh man, look, that's where I grabbed really hard. It's like, oh yeah, that's the iatrogenic break
Yeah.
I made.
Oh, yeah. So
But
yeah, no, it's
do you
really
do
ugly.
any free flaps at all? Is that something that you like to do? Is that something you recommend?
So I mean, I've had to do a free flap inadvertently in a case where I amputated the flap and there was nothing left. Whether it actually stays there, with the patient's post-op and like, see the time from the surgery being done, your gas exchange, because I usually do my gas exchange once everything's out of the eye, so I don't actually know if that free flap
Mhm.
stays or not. So it's not something that's routine in my practice. As much as possible, I try not to. But for re-offs, somewhere what I've done is I do macular hinge dissection. I don't know if you're familiar with
Love
that, but
it.
basically just
Love macular
excellent.
hydrosection.
Yeah, and I learned that from my fellowship director, Dr. Ephraim Mandelkorn, who published this technique, and so I just attached the softer cannula to the TB syringe, and then inject very gentle VSS, and I find that detaches the macula, and then I try to obviously enlarge that previous rexus, and do that rotational flap that I showed in my technique, and then inject some viscoelastic. I've done that for 2 cases, and they were successful. Like the visual recovery, of course, is a bit worse because then you have to rehab, but success is there. But I know a lot of our colleagues do like retinal autografts or free flaps. It's just something that it's not on my go-to. So it's not just possible to try the other stuff
Yeah, same here.
first.
I like the induced macular hydro dissection, induced detachment. I agree. The anatomic success is high because I mean, I think the thought process is that the tissue is so scarred down by redetaching the retina, you allow it to sort of relax in a more natural state. I've noticed
Mm.
that the amount of pressure, because I use I actually go into viscous fluid injection mode, and I use
Yes.
the 39 gauge subretinal cannula, and I think it works really well. You can even use the regular um, oil injection kit and just fill it up with BSS. But the one pointer is that the injection pressure is a lot higher than you would think. It's closer to 15 to 16 in my hands, at least, compared to 10 to 12 that some people talk about. I have a question for you actually. So I recently, just this past week, had a surprising non-closure of a macular hole. So I'll share that with you and tell you what I did, and you can give me some tips when I have to inevitably reoperate on this patient. Okay, so this is a 60s, you know a pseudophakic lady with a chronic macular hole who came in to see me after their cataract surgery, and they have this macular hole. As you can see, it's about 425 microns. It had
Yeah.
some chronic signs. It didn't really look chronic on exam to me. So in this situation, I ended up basically just doing a standard ILM peel, peeled about 2 disc diameters around the foveal center.
Yeah.
But the problem is they came back and they still have about maybe 40% gas, and they've been doing strict phase down positioning, SF6 gas. And you can see here there's some RNFL changes here, but the hole is still open. It's a little bit smaller than it was before. You can see here it's probably about 320 microns, and obviously I went up on the anti-inflammatory steroid drops, but it has a pretty flat configuration, as you can see. Sometimes if I have a nice
Yeah.
bridge, a drawbridge configuration, the likelihood of it closing with anti-inflammatory drops, prednisolone, ketorolac, or bromfenac can be helpful. But in this case, I don't think this hole will close. So I'm seeing the back actually
Mm.
tomorrow. So I was wondering if you had any tips or tricks in this situation to try to get this hole to close.
Yeah. Well, first of all, I'm sorry that it closed, but the good news is it sounds like you only peel 2 disc diameters. So maybe now you have some room. I would probably take the MACULAR, like first available date that I have, and then I would do everything. I would throw the entire like kind of all my toolbox in that for that case. Like I would do macular height dissection. I would enlarge the rexus in multiple different directions, and then do a rotational flap on each side, and then inject physical cohesive material, and then do obviously face down SF6.
What I was planning on doing in this
Yeah,
case, so, I mean, the thing is, back in the day, all we used to do was a vitrectomy for a macular hole, and oftentimes it closed at pretty high rates. I mean, to
yeah,
me, this is a small hole. It's 425 microns.
yeah,
That's why I didn't peel aggressively. So
yeah.
I'm definitely going to widen the peel. I'm also planning on doing macular hydrodissection and might even do C3F8 gas. But, so these are all amazing techniques and videos, and really appreciate you sharing them. Before we finish, do you want to just walk us through, just for our audience, your sort of algorithm? How do you determine what technique you'll use? Does it depend on in the OR, or do you go in depending on the size of the hole, the chronicity, which technique of these you're going to use, or do you go with what the eye gives you?
Eight times that question. I would say, unless if a hole is small, which, as you know, obviously like acute or small, for those holes, I just do routine ILM peel, SF6, nothing fancy, and most of the time they close. 99% of the time, I would say. From anything medium to large to chronic to extra large, I almost always make a note in the OR booking form, do flap. And then I, review the charts like the day before, and I'm like, flat, flat, flat. I even tell the nurses, like, we're doing flat for those cases. And then anything that's large or extra large, I do viscoelastic as well. And with the Tano, I try to make sure that the flap is actually sitting totally on the hole, that there's no like question about it. And that I don't go home wondering if the flap is still on the hole. And so I would say that's my routine. So I would say, probably 70% of my cases are getting flats, which is nice, because then that really helps me sleep at
Love
night.
it. Do you put the viscoelastic on the flap? Help it
Yeah.
sit down. Do you do that
Yeah.
before or after your air fluid exchange?
Before the fluid
Okay.
air exchange, yeah. So I, put the flats on with with my forceps, and use the soft cannula or the Tano striker to make sure the flap is sitting nicely flat. Then I inject the visco cohesive material, and definitely not visco dispersive, because I've been burned with this, but dispersive, where it's like stringy spaghettis and nothing stays. But visco cohesive actually sits it down. And then, in videos, you see people saying you have to make sure all the visco cohesive device has been taken out with your fluid air exchange. We don't actually have to. I mean, that can just stay to the bottom of the eye at the end. But so I still stay on the nerve. I don't bottom the macula for the fluid air exchange part. I just stay kind of super nasally to the nerve a little bit, and then make sure the flap is down to the end. And then make sure it's a complete FAX. Like there's no questions about whether there's, full gas fill.
Awesome, Dr.
Okay.
Arjman. Thank you so much for your time and for sharing these tips. I'm sure our audience is going to have a lot of questions, comments, and I know it's going to help a lot of people. And I've definitely learned a lot from you. Thank you for your time.
Thank you so much, Dr. Zaid. And I also learned a lot from you. Thank you so much for the honor of being on your podcast. And I look forward to seeing more. Peace.
Thank you.
Thank you.